Thanks to the chairperson and thanks to the entire organizing team of INASL for this wonderful meeting and inviting me for this talk. So I think like the chairperson said, the stage has already been set, a lot of discussion has already happened, and you already know the controversy whether this disease should be given any importance as a separate entity or should be you continue to call it NCPF or INCPH. But my talk is to tell you the similarities and differences between these two entities and how it is going to be perceived. And maybe that will help you make your own opinion whether you want to call it a separate entity or you want to call it the same entity. So let me take you through some historical aspects and the previous existing definitions. So in 1976, in Japan, this was the term used for this entity called idiopathic portal hypertension, where the patient will not have cirrhosis, have portal hypertension, and have a very good liver function without any evidence of decompensation for many decades. Then the EASL gave this definition in 2011 and called it INCPH, or idiopathic non-cirrhotic portal hypertension. And this is how they defined it, that you have to have clinical signs of portal hypertension. So portal hypertension is a must in INCPH. Exclusion of cirrhosis on biopsy. All cases of NCPF, INCPH, you have to exclude cirrhosis. And nowadays you can do that with the help of a fibroscan. So remember, a fibroscan value of less than 10 in a patient who has portal hypertension should alert you that you might be dealing with this particular entity. Exclusion of specific etiologies of CLD. So if the person has hepatitis B along with this, ICPH is out, patient will be got chronic hepatitis B. Exclusion of specific conditions causing NCPH and patent portal vein hepatic vein. So if you have a portal vein thrombosis, that is EHO, then you cannot call this patient as INCPH. So these were how these parameters used to define INCPH by EASL. And we, over last 5-6 decades, have been using the term NCPF, which was also described almost in 1960s, 1970s. And in APASL consensus meeting in 2007, they used a common term, either NCPF or IPH. See, so much confusion. So NCPF or IPH defined as a condition of undefined etiology associated with periportal fibrosis involving small medium-sized portal vein branches resulting in portal hypertension. So again here, portal hypertension is a must with normal liver structure and function. And we all know that over last few decades how this prevalence of this entity in our practice also, as well as described from Japan, has been declining. This is more than 3,000 patient data before 1990 and more than 3,000 patient data after 1990. So earlier almost 1/3 of patients of portal hypertension used to be we were used to seeing NCPF or INCPH as one of the causes, whereas now it has declined to almost less than 5%. And then this term was defined by the Waldeck group called the portosinusoidal vascular disease, and maybe Akash will throw some light later on what was the reason behind changing the name. There have been a lot of debates about changing the name of NAFL to MASL, so there is also a history behind changing this name from INCPH or NCPF to PSVD, but is it really a separate entity? And this was also endorsed by the Babino 7 consensus. So how is it defined or diagnosed? So they defined it as a broad clinico-pathological condition. So an umbrella condition, entity encompassing a lot of conditions like NCPF, idiopathic portal hypertension, non-cirrhotic intrahepatic portal hypertension, and various overlapping histological patterns, including NRH, obliterative portal venopathy, hepatoportal sclerosis, incomplete septal fibrosis. So a lot of clinical entities which were known by different names across various geographical areas, and a lot of overlapping histological entities were clubbed together to give a name of PSVD. So it is essentially a histological diagnosis that must be understood. So the first step in making a diagnosis is to exclude the presence of cirrhosis by doing a biopsy. Second step is to demonstrate one specific sign of portal hypertension. So exclude cirrhosis and show that the patient has portal hypertension, or at least show one specific histological lesion for PSVD, which I'll define later, or show one non-specific sign of portal hypertension and one non-specific sign of histological lesion of PSVD. So what are the specific signs of portal hypertension? Either varices, defined or described portal hypertensive bleed documented, and collaterals or collaterals at imaging. So any one of these, absence of cirrhosis, you have PSVD. Or a specific histological lesion, either OPV, obliterative portal venopathy, or NRH, or incomplete septal fibrosis. So either of these, then you have PSVD. Or if you have a combination of non-specific findings, which I have also described, which you can go through later. So what are these specific histological lesions? So this is a normal portal tract in which you have a large portal vein branch, which is about 3 to 4 or maybe more times the diameter of the attending the artery as well as the bile duct. So you may have multiple, at least 2 to 3 or 1 to 2 branches of bile duct or hepatic artery and a single large portal vein branch. So what happens in PSVD? This is the classical histological description called the OPV, or obliterative portal venopathy, or stenosed portal vein in simple terms. So a portal vein diameter which comes down to almost similar to a hepatic artery branch or a bile duct branch, or even smaller than that, or it even disappears. Absence portal vein branch in a portal triad, or an incomplete septal fibrosis, which is extension of fibrous septa from the portal triad but not forming nodules. So they will traverse the lobule but not form nodules. So these are the specific lesions. But are we just trying to put the old wine into a new bottle? Because this term, which was defined as the sine qua non of PSVD, was also called the histological hallmark of NCPF as far back as 1969 by Dr. Nayak and Dr. Ramalinga Swamy from India. And they also described in NCPF intimal fibrosis, elastosis of veins, aberrant vessels in the portal tract, incomplete pseudonodules, scattered regenerative nodules, or NRH. So almost the same histological criteria which have now been defined in the PSVD. So this part is definitely similar. So what is different? Also, if we look at the risk factors, some of the risk factors which have been described for PSVD, for example, prothrombotic conditions, immunological disorders, certain infections, certain drug exposures, are also the risk factor described for NCPF or INCPH. So what I want to say is that it is an umbrella diagnosis which encompasses a lot of other disorders. So let's see what. So it encompasses, when in presence of portal hypertension, INCPH. So it encompasses INCPH as part of that umbrella diagnosis. And when in absence of portal hypertension, it encompasses those patients who have typical features of PSVD on histology without cirrhosis. So no portal hypertension, but you do a biopsy and you find OPV, then it is PSVD. It also encompasses chronic liver diseases, including, say, chronic hepatitis B, chronic hepatitis C, MASLD, or ALD, who have not yet developed cirrhosis, but if you do a biopsy, you find OPV. So a CHB patient who has OPV but not developed cirrhosis will also be called PSVD. And portal vein thrombosis is included. These conditions were a priori excluded in INCPH. So what this diagnosis of PSVD does is it fills this diagnostic gap. It includes this as well as these conditions, and together they are called PSVD. So clinically, do we see this? You just heard in the CPC Dr. A.C. Anand presented a fantastic case where he demonstrated that everyone else was thinking that this would turn out to be a NAFLD, but it turned out to be PSVD. And patient was otherwise asymptomatic, did not have portal hypertension, did not have ascites. So let's see, are there some studies which talk about this? So this is a Spanish study in which they looked at 155 patients who histologically had PSVD and then looked at the prevalence of HBV. So it was seen that patients who had PSVD had a higher prevalence of current HBV infection as well as past HBV infection as compared to the general Spanish population. And patients who had a combination had a worse prognosis, delayed diagnosis, higher chances of going into liver transplant. In other patients, day in, day out, we see patients who have unexplained rise in transaminases. Despite everything, we are not able to reach a diagnosis, and we label them as having maybe NAFLD. 144 patients who underwent liver biopsy for unexplained elevation of GGT, 67% had PSVD, published recently. They have reports, a European study. The key predictors of PSVD were male sex, LSM less than 10. So any patient you are suspecting as having a portal hypertension, maybe CLD, but LSM is less than 10, think of PSVD or INCPH, whatever you may like to call it, and a GGT level less than 200. Similar to INCPH, the exclusion criteria are similar. You exclude other vascular causes, HVOTO, sinusoidal obstruction syndrome, congenital hepatic fibrosis, sarcoidosis. These are excluded in both. Do we have natural history studies? Are these different? Are the natural history different? So we have two small studies, recent, but yes, we need more work. So this was a study in which from among patients undergoing liver biopsy and HVPG for varied reason, who met the histological criteria for PSVD. So 91 patients, 28 within this as a subgroup were also labeled as having INCPH because they had portal hypertension. So this group, no portal hypertension but PSVD. This group, portal hypertension, therefore INCPH. Median follow-up, 37 years. And again, yes, those who had portal hypertension, hepatic decompensation was higher. Those who had just OPV had a benign behavior. So PSVD without portal hypertension or OPV without portal hypertension may not have a clinically significant outcome, whereas once you have portal hypertension, that is similar to INCPH, you have a poorer prognosis. Another study, OPV without portal hypertension. Remember, OPV without portal hypertension is PSVD. So 428 patients with non-cirrhotic CLD who underwent a liver biopsy, 20% had OPV without portal hypertension. These were compared to 20 patients with INCPH, and they found that the prevalence of NRH, incomplete septal fibrosis, was more so in patients with INCPH, suggesting that PSVD may be an earlier stage of INCPH, but we don't know this. We need to have more data, more longitudinal data. Their laboratory parameter behavior was similar. Their prevalence of other extrahepatic immune disorders, prothrombotic states within the two groups were similar. So these are my summary slides. Take home of similarities and differences. Definition, yes, there are many similarities, many differences. What are these? Histology. So OPV is a lesion which is defined in both the conditions. So OPV has to be present in both these conditions, but OPV is a defining lesion for PSVD. Absence of cirrhosis. So absence of cirrhosis is a similarity. Both conditions, there is absence of cirrhosis to define them. Specific vascular diseases excluded. I told you sinusoidal obstruction syndrome, sarcoidosis, other vascular disorder excluded in both. So that is a similarity. This is a difference. Portal hypertension always present. INCPH, portal hypertension always present. PSVD, even in absence of portal hypertension, you make a diagnosis of PSVD. Specifically if there is a histological OPV. Coexisting liver diseases allowed, not in INCPH but allowed in PSVD. So chronic hepatitis B patient, pre-cirrhotic, you do a biopsy, OPV, that is CHB plus PSVD. Portal vein thrombosis not excluded. So Portal vein thrombosis develops in the natural history of INCPH in almost 30% patient, also in PSVD. But if a patient has OPV and concomitant portal vein thrombosis, patient is still PSVD, but not INCPH. Natural history, once the patient develops portal hypertension both in PSVD as well as INCPH, prognosis is similar, they behave similarly. In pre-portal hypertensive patients, we still do not know the prognosis. It may be a benign disease. Thank you for a patient hearing.